As far as the average score?
No, how many to be screened to have a positive score?
Well, a positive score probably be a low number, 2 or 3.
2 or 3? Okay.
Yeah. Maybe 2 on average, because your prevalence is 50%, so you'd screen 2
Right.
and find 1.
Okay.
Yeah.
Let's see here. Ah. Okay. Sorry. Oh, no. Now I gotta put on my glasses. Okay, all right, great. Okay, so let's see what else. So here you can see, so having a, so can you read this now?
Yep.
So having a 0,
Right.
38%.
That's fine. Yeah, so 0, I don't think that's right. Greater than 0. So if they had any plaque, 38% had any plaque, and those had a score of 100 was 13%. So about 1/8 of the people had a score above 100, which is high risk. So that's a very dramatic finding in an asymptomatic population.
And then there were 2 that were in the 500, and we had somebody over 700. So I just had somebody in our Campbell community who's over 1,200, and he was 66 years old.
Do you know the ages of the 400 to 499? I mean, you probably do.
Specifically,
Understanding. So we have 4 that are 100 to 200, 3 that are 200 to 299.
Those are just individual patient counts. So,
Yeah.
yeah.
But so for those unlucky 13%, what are their, do we know their average ages?
I don't have the data here. No.
I don't know about, yeah.
I think Bob did this initially.
Yeah. I do know that it was men over 40 and women over 55. But we could probably get that data. So again, here between, here we go, between the ages. And here's the slide we're looking for. I told you I could get this information. I mean, I'm quick. I am really quick. So between the ages of 30 and 50, 25, so a total of 25. Over the age of 50 to 65, we had 63 patients. And then over 65, 16 patients.
Okay, so 3 of them were above the 75th percentile, which puts them in the definite medication category, right?
Mhm.
Yeah.
Yes.
And then 10 over the age of 50 and 65. And then over the age of 65. I didn't do these slides, so bear with me, you guys. I reviewed them, but so again, here we see 10-year risk calculator. Matt, do you mind talking about this piece?
No, that's, so this is just looking at what risk they were. So this is just looking based on their ASCVD risk. 39 out of the 50 that did the risk calculator were considered low risk. 20% were intermediate risk. 12% were kind of a little bit higher. I don't know, that's the overall. 30%, let's just say, were intermediate risk. And then just 1 person was high risk who got scanned.
So after we did the study was when we rolled out into the community. So I've done 10 different community screenings. We've screened almost 400 patients. And like I said, we were at about a 32% that we're finding are over 0. I just started a program with the Scotts Valley and Santa Cruz Police Department. So after talking with Matt about LA, so we just did 55 first responders last weekend. And again, I think we were at about 31% have something more than a 0 from just those 55. So it's pretty exciting. It's pretty exciting what we're doing out there.
It's amazing. I mean, most people would go through losing a husband while they're raising their teenagers, and they wouldn't motivate doing these wonderful fundraising events in the community to build the scanning unit. work with experts all around the country. She's on radio, she's on TV, she's out there saving lives every day.
I think it's what they do with the information, and what you guys do with the information too, right? But it really does make a difference. People are very, very motivated when they have a positive score, for sure. Okay, so what's up next here? Now, if you could speak about this, of the DNA and the RNA.
Yeah, this is something that, well, I think we're trying to get some more advanced markers. There's a thing called META-GRS, which is a genetic testing that's done mostly in Europe, but they're trying to now correlate it with some of the calcium stuff. So we're trying to look at the genetics and the calcium to try to see if we can identify better correlations.
And I think through this study, Bob was saying that there was definitely a parallel right now.
Yeah.
Yeah, just in the beginning stages, yeah. Okay, that's it. Thank you so much.
Dr. Ramirez-Aniga from California Health and Wellness has a question.
Yeah, actually, a comment. California Health and Wellness in California. You gave a presentation about 2 years ago, I think, within a month or two, CAC scoring became a medical benefit, probably prompted by the presentation and some of the discussion that followed on the discussion afterwards. So thank you for that. So it's now a medical benefit.
Oh, it's a Medi-Cal benefit
Yes.
right now.
So one of the questions that came after your presentation is who covers that, similar to the discussion that we had today. And from that came a recommendation to pursue this at the DHCS level. And somebody heard, and within a couple of months, they made it.
Wow. This is the first we're learning of this. We were just talking about, how do we get the guidelines to be adopted by the carriers? So California Health and Wellness covers it?
All managed care medical, actually all fee-for-service medical recipients in the state will have access to this. I believe it was of October of 2017, following the AHA, the American College of Cardiology, AHA guidelines.
They'll pay up to a certain amount, or they pay the whole thing, or?
Everyone follows the medical fee
Yeah,
schedule.
they follow it, so they have to be, the center has to take the Medi-Cal.
Yeah, that's why they contract the managed care. We follow the medical Monday fee schedule.
So you're saying, so Medi-Cal requires it to be covered through the fee-for-service side,
Everybody.
and so the Medi-Cal managed care plans also have to
Correct.
cover it.
Whatever medical service in terms of becomes a benefit, becomes a benefit automatically in the managed care. And they have guidelines, and the guidelines are following the AHA, American College of Cardiology recommendations.
Well, thank you for bringing that information to us.
Thank you for that.
That's what, 14 million lives now
Yes.
in California? That's potentially something where, people were asking me, could we bring a mobile scanning unit, for instance, to areas of high heart attack rates? And potentially now with that, it could be covered. So that's really important news. Because we were just having a conversation about, okay, if we only have enough funding through our fundraising to scan, say, 100 people in a high-risk zip code, how do we prioritize beyond that middle risk category? And the answer was middle risk plus the family history. But now it sounds like we could just do the middle risk, at least for the low-income people. So they would have no copay or some copay?
There's no copays in medical managed care.
Fantastic.
Specifically for calcium score.
For any benefit of under managed care, is zero copay.
So UC Davis, I know, has a screening area. Bill, do you want to talk about how this meshes?
Yeah, couple things before we get to that. I had a couple questions for Matt and Victoria. I noticed in your data, this is what we call a screening test. We're not using the word screening, we're using triage so that we don't use that screening because people object to it because of a couple things. Too many people may need a test, you may generate unwanted procedures, things like that. People are sort of negative about screening. And that's why we've had difficulty with the U.S. preventative screening for it, because they feel that too many people might get into it. We generate additional procedures, and we haven't yet shown outcomes or reduced mortality for the group that got it. So looking at the data that Victoria showed, I noticed that it was over 40 was the inclusion criteria, and I think that's important because obviously coronary calcium goes up with age, so that very young people are less likely to have it unless they have risk enhancers or modifiers at that time where they would be candidates. The other was in your group of individuals 65 and older, it was all but 3 of those did have positive coronary calcium at that time. So would you say the inclusion criteria, if you had to refine that, would be perhaps individuals who were 40 to 65 years of age? That would give you a bigger chunk of these, quote, intermediate patients for which your risk adjustment or reclassification makes most sense at that point in identifying those individuals. So perhaps what we need to do is sort of refine the criteria of those going into the program so that we can make sure that we get the maximum use and more efficient use of this, quote, screening or triage procedure for that. So that would overcome one of the objections of the U.S. Preventive that we're doing too many tests in individuals who would not necessarily benefit or change. The other criticism of screening tests is that we generate data that leads to other procedures, diagnostic procedures, etc. And so there's a concern that if you then walk out of the office with a positive calcium and now you're going to say, oh, I'm having chest, maybe that is indigestion, well, maybe it's not, it's chest pain. Now I need to go to the ER just because I ate something badly and I've identified it at that point in time. And that's always a concern. There is also the so-called drive-by diagnosis where you do the calcium or the CT and you detect something else. Well, it's of interest, and this is now anecdotal because we wrote an article for RightCare Initiative and we published it this year, and it appeared in the San Jose Mercury as an opinion article in the paper. And so I was expecting that you might get some drive-by cases of this caused this or objections, etc. And we did get some information, and I got one letter nicely written about that. And that was about an individual who read the article, went to their primary care physician and said, I need to have this test done, and they got the test done. And interestingly enough, what was discovered on the test was that the calcium score was there, and that was dealt with. But in addition on the test was a mass in the lung, identified on the chest CT, just with the calcium scoring for that. That individual subsequently, as it was asymptomatic for it, went and got further testing and then had surgery 2 weeks later because of the calcium scoring. And the surgery successfully removed a lung cancer, which was felt to be a fatal or lethal lung cancer in that patient. Today is still doing well 6 months later at this time. So this was a drive-by, and she wrote a very nice letter that she felt that mention of that coronary calcium had saved her life in that particular situation. So there is some drive-by data that accumulates, but it's how you handle that, and in this case, I think it was handled appropriately, and it indeed saved her life. So that's one of the things that I was going to address to Matt and Victoria as they go on this screening mode. how do they handle, or have they encountered any, let's say, additional diagnosis? Because we know as we get older, we'll probably have something that shows up in addition to coronary calcium on a CT scan.
Yeah, I haven't had any major incidental findings yet. Obviously, those are important. We can see bone density as well. We haven't formally measured all of the bone density, but another opportunity is, number one cause of death is heart disease, number two cause of death is lung cancer. Those are both visible on the same scan. And then bone density, we can also see, which is important for the older aging population for osteoporosis, because the spine is also in the picture. So there's a lot of opportunities there. I don't think we've seen any lung cancers yet, but again, it's only in the few, we are like 100 and something that we've really fully analyzed. I think Victoria was sharing some of the expanded data more recently, but I don't think we have all the data yet quite incorporated.
So the particular lung cancer case that Bill was talking about was found at Stanford, and I know of at least one other cancer case that was found through this trinomic screening that you just did.
Okay, so I'll have to check that out, yeah.
And it's stage 1, and it's absolutely life-saving. So I do have, we have another question here from the audience. Could you say your name and institution, please?
So I'm Kelly Grady, I work at UC Davis. I guess, so maybe in the last couple of years, there's been a recommendation for low-dose CT screening for patients with a history of smoking. I mean, is this something that should just be a combined test where they're doing that screening and checking a coronary calcium score at the same time?
Good for you, Kelly.
Well, it's very, very easy to get a calcium score out of a low-dose lung screening because you cover the entire lung and the heart is in the middle of that. The opposite is not always true. When we do a heart scan, we don't get the entire lung. So actually, your algorithm would be more comprehensive to do full lungs and then focus in on the heart. The problem is if you do it in non-smokers, you get a lot of little nodules that then cause consternation and require follow-up that are probably not real, because we all get probably little lumps and bumps from breathing or clean air. Not as beautiful as outside there all the time. So, yeah, so I think that's the reason why we haven't gone down to let's just get a full body scan or a lung scan of everybody, right? But it is easy to measure a calcium score off of lung cancer. Off of a lung cancer screening. We're trying to get more radiologists to do that. It's not uniformly. I think Joe and I were talking about that before. It's not uniformly done, and that's a problem because it's recommended that they do the calcium estimate at least. You don't have to give an exact number, but you can say there's mild, moderate, or severe calcification in the coronaries, and that could prompt further evaluation or treatment.
So I'm wondering with the California Department of Public Health, whether you might send a letter of advisement about that point she raised?
I'm so sorry, I was out in the restroom, but
I was just saying that with the recommendation for prior smokers to get scanned,
yeah.
could it be that the recommendation would now be to get them done simultaneously? Because it's captured in the same
So that it's
issue.
record.
Yeah.
The key
Oh,
is that the radiologists have to read, right?
yeah. I would say that recommendation is actually in the U.S. Preventive Services Task Force, so that kind of is one of those sacrosanct type things. But I would imagine the radiologist, if they would remark upon calcification in the heart. I would believe. Yes? No?
They often don't, and this is
Oh.
one of the things that's in Steve Sidney's paper about the young cardia study, is that there are all these incidental findings that no action is taken on when you find any calcium in any CT scan. Action should be taken.
Well, thank you for bringing it to my attention, everyone. And I will bring it back to the heart program to look into it.
Thank you.
So one of our patients that we had, just to kind of piggyback on this, the one that just recently got a stent, and he had kidney stones back in February and had a CT scan done, and it was not reported, his calcium score. And so he came on our bus, and when he got his report, his very good friend's wife had just recently recovered from a heart attack, and so he went to his physician, and he did get a stent. And when they pulled the film out, the data was there back in February,
Huh.
and
But not listed on the radiology report.
And I'll just say that Kaiser's not in the room right now, but when we found out from Gunderson, so one of our team in Los Angeles is a former Gunderson executive. And he had Mike Dolan, the executive vice president of medicine for the top performing health system in the country, Gunderson, come out and speak to us about what they found with regard to incidental findings, which is that he took his angiography patients and he asked that the electronic medical record be looked at to see if there had ever been a CT scan, well, he said in the last 6 months, and if there had, he had medical students from University of Wisconsin look at the correlation between what was found on those incidental findings of CTs for other matters and angiography, and it's nearly 100% correlation. Now, we've been trying to get him to stop and write that up. He's
Yes.
so busy, and even to work with, world experts to get it to be known. Because as soon as I learned that, I called Mike Cantor, the head of Kaiser Quality Improvement for the Nation at that time, and said, can you look back at your EMRs? This is urgent. And he said, we really just don't have a way to do it. But we do, so Bill Baumer here, cardiologist UC Davis, is an expert. Both of these gentlemen are experts in using computers to find things in addition to for population medicine. So can you talk about how could we find, so to me, I wake up at night and I think we have all these incidental findings, how can we act on them?
Well, I think what we need is some journal articles detailing the issue, and then maybe a conversation with the radiology, societies, right? That to me is the way, I don't know that a letter from us with no evidence is actually going to make a difference, but it is an important point that needs to be raised.
Well, the radiology, the Fleischmann Society has a thing on recommendations what to do with nodules, so it's all pretty well spelled out on the size, and they've updated it recently. If it's beyond a certain amount and a different age and a different risk profile, then you do this, and check it in 3 months, 6 months, or a year, or don't have to do it, but they're looking for it. To answer your question, they use can screen for, you asking about screening for high-risk cancer patients. And what I usually do is put on to do the whole one if they're a high-risk patient for cancer.
Right, yeah, no, I think the recommendation was like if you were a former smoker that now Medicare covers a low-risk CT just as a
Yeah.
screening scan. If you're scanning it anyway and you can make you see it, the radiologist, it's just a reading, there's no reason.
Well, your place, man, you offer that too.
To test.
Because they offer it to do, but you can do, you can't do add it on to the test when people go in and get it. It's something you got to think about adding on to it. It's an extra income for them.
Oh, yeah.
Low mineral density, well, that's probably not quite ready on time yet.
Life Saving Images is going to be doing clinical screenings at some point. On our bus currently, though, it's a different software is what I'm told. So right now, we're just doing heart scans.
I mean,
So
if you're
this
scanning the same
idea-
area and you can
Yeah.
see it, then there's no sense in exposing a patient to radiation multiple times, whether it's Lewis or not. When you can get the information from the same scan, what Linda recommended is just to have it as part of the order. And
So
maybe at UCA, that's something we could do, is when we're ordering a low-dose, or we're ordering the low-dose CT versus screening of lung, that we ask them to calculate a coronary artery score at the same time.
So this is definitely something where we need the help of public health, because I remember when I was in my 40s being flagged on my mammogram for having a strange pattern of calcifications. Well, in the last couple of years, it's been written up that that is indicative of coronary artery calcium. And so those incidental findings, honestly, the doctor outstanding down in Palo Alto, she was like, I just don't know what to do with this information. So we know that we're not doing a good job in translating information from women's health to cardiology. We've now had multiple presentations where, for instance, women with preeclampsia in pregnancy are at much higher risk of heart events, cardiovascular events, and yet that information isn't being carried over to protect their hearts. So I don't know who, I'm so happy that you have a new director, Sonia Angel, coming in, who stood up the cardiovascular disease program for New York City. Yes!
Yay!
And we're hoping that you and she will be with us on November 18th back here for our gathering of the troops from across the state.
Yeah.
So I know we're,
And Hattie, maybe we can report back on, exploring this, because I will bring it back to Jessica. She's on the Council for Science and Something Affairs at CMA, like that, because I'm just trying to think of what are the ways that we can go to raise awareness of this issue. So that might be another route.
we would really appreciate your ideas on how to get it into use.
Yeah.
Yeah.
Well, I'm not the expert on this, so any ideas you all have too are really important.
I'll say one thing, the Preventive Health Services once been slow to adopt this, and the same way all the societies were slow. I've seen this through the years of wanting outcomes, they want data, they want this. Now they want longevity to show that it does. Well, it's very hard to take a diagnostic test and show that it's going to life unless you act on it. And you have to have a population of primary care physicians and systems that are not only know how to order it and how to get it, but then how to move to treat it and to do it, and then you'll start to see the outcomes. So it's much harder. So I wouldn't count on the U.S. Public Health Service, task force to really be coming out and endorsing this anytime soon until we can go.
But what
But maybe
California does,
ICER might, though.
What's it?
ICER might, yeah.
Yeah.
If they adopt this to look at, that might be helpful.
I was also saying that your slide on the Chinese saying. I have a friend whose wife is a Chinese thing, and I had to read it without telling her what it said. And so this is classic Chinese. It's the old Chinese characters, and she read it exactly. So it is exactly like independent knowledge.
so one idea that maybe somebody in this room knows what to do with, our former dean of the UC Berkeley School of Public Health said, well, you're scanning the same part of the body as mammography. Could it be that you could change the test so that it would be testing for both?
For mammography.
Yeah.
We don't have enough data on breast calcifications and how prevalent they are, I don't think, yet to do both at once.
But could you change your mammogram? Say every woman, when she gets her mammogram at age 50, would also get the coronary calcium score done. Is the machinery
Different,
Yeah. You'd have to open the window, yeah. You have to do, it's a different area of the body, even though they're close proximity, but they are different, so you have to load the scanner and scan different parts of the body for that. And in one, you're looking at soft tissue, and in the other, you're looking at calcium, so you're going to set your parameters a little bit different for it. But I think it is important when you talk about the lung scanning for smokers, because smokers clearly are at risk for lung cancer and for heart disease, and it would be key in those individuals who are coming in for that screening for lung cancer. I think those would be quite appropriate to include a window that would look at coronary calcium in that population, so that would be very helpful. And it reminds me that we accumulate a lot of data on our patients, so much data on our patients, I can't literally read through all of the tests and data of the patients that I have. It would take me more than a 15-minute visit to just actually speed read through all of the reports and everything else. So where do we go? We have the problem of big data, so much data on these patients accumulating